Welcome to SheTV.com, where board-certified physicians talk to you about women's health. In this episode, Dr. Dana Bock, a board-certified anesthesiologist, explains what the options are for prevention of post-operative nausea and vomiting for patients who have had severe post-operative nausea and vomiting in the past.
Hello, I'm Dr. Dana Stone. I'm a board-certified obstetrician gynecologist. I'm here today to talk with my friend and longtime colleague, Dr. Dana Bock. She is a board-certified anesthesiologist, and we have been working together for many years. She's
Yes, we
got some
have.
information. Yeah, she's got some information about patients who have had a history of nausea and vomiting with surgeries. I have many of those patients that will, as we're talking about their surgery, they'll mention that they have had that problem in the past, and I know that you have good options for them.
We do have good options for them, Dr. Stone. First off, hi. It's nice to visit with you again. And what we want to do is just educate you as a patient so that you will know when to bring this up. Letting your obstetrician gynecologist know that you've had trouble, especially if they're planning a surgery or talking to you about a surgery, is an excellent time for that to get put in the chart. Usually there's a pre-op call by a nurse from whatever facility you'll be going to if you're having surgery, and they will usually ask someone on that end will ask, do you have any difficulties with anesthesia? And you want to pass that along. And then your anesthesiologist or anesthesia care provider will come in and visit with you right before the surgery. And that's when you really want to mention that you've had trouble in the past. When I get told that in our operating area, there's several things I want to know first. I guess at the facility where I work at Lakeside Women's Hospital, we are taking care of women. So women have post-op nausea and vomiting more frequently than men. The younger population has post-op nausea and vomiting more frequently than the older population. And non-smokers have nausea and vomiting post-operatively much more often than smokers. So many times, if you're coming in for a gynecology type surgery, you're the female, if you're young, and if you're a non-smoker, you're coming in with, I always say you've got 3 strikes against you. And that's kind of a setup for you may have post-op nausea and vomiting. Another thing that can increase that risk is if you have a history of motion sickness. If it's mild, maybe not too bad, you may be fine. But if you're one of those people that can't ride in the back of a car or has to wear a scopolamine patch when they're on a cruise or on an airplane, then we want to know that ahead of time too. And we will probably need to pre-treat you with a scopolamine patch and just put that on and let you wear it during the surgery and the day of the surgery so that you're hopefully taking care of that motion sickness component. Narcotics, if you're having a major surgery that's going to require quite a bit of narcotic for post-op pain control, then that can also cause post-op nausea and vomiting. More related to the narcotic, but we want you to be comfortable. So sometimes we have to just take care of the nausea that may be associated with the narcotic too. So those are all kind of major risk factors or reasons that we'll see patients experience that postoperatively. And nowadays we like to try and prevent it. And our best way at preventing post-op nausea and vomiting is to use our induction agent, propofol. It is the white medicine that we use through the IV to get patients off to sleep. And so it can be used as an induction agent, and then we will run it on an infusion pump, and it becomes the general anesthetic or most of the general anesthetic for the case. So once I use it to get a patient off to sleep and get a breathing tube placed, then I'm going to program this pump, and the pump will let that propofol run continuously through the IV as the general anesthetic. Sometimes we'll add just a little bit of gas in through the breathing tube, but the smaller the amount of gas, the better in someone who has a history of post-op nausea and vomiting. So propofol infusions usually decrease severe post-op nausea and vomiting. It takes it away in about 60% of patients where they experience none, even if they've had severe post-op nausea and vomiting in the past. In that other 35 to 40%, they may still experience some post-op nausea and vomiting, but it's much, much less and it's much more manageable. So they're not needing an emesis basin or a bag for the next 6 hours. They may just think, I'm a little nauseated, but I'm not being sick. And so I'm not having to use my abdominal muscles to be sick and throw up with. And after you've had an abdominal surgery, you don't want to have to use those muscles to be sick.
No, you do not.
Yes, if we have a little nausea but no vomiting, it's much better than if it's severe both ways. So that's our best way to treat it. The other couple of things that we like to do is Zofran, or ondansetron is its other name. It is a very good anti-nausea medicine if we give it preemptively. So to give it, we normally will give 4 or 8 milligrams of it IV during the surgery, so before the nausea ever gets started. And we normally will combine it with a steroid like dexamethasone or Decadron. If we give a small amount of the steroid together with it, it greatly decreases post-op nausea and vomiting. And then the other way we like to treat it is to try and use the least amount of narcotics as possible. So patients may still need narcotics during the anesthetic and for a short time in the recovery room, or maybe a dose or two out on the hospital floor. But we like to give Tylenol in the pre-op holding area, and we like to get it going on an every 8-hour regimen for the first day, the first 24 hours of surgery. And we like to add Toradol or ibuprofen. Like Toradol is an ibuprofen nonsteroidal like drug, but it can be given through the IV. And so we like to give that at the end of surgery if we're having no issues with bleeding, and get it started on an every 8-hour regimen too. And so those two drugs together will greatly decrease how much narcotic pain medicine a patient may need, and again end up helping that patient have less post-op nausea and vomiting.
Great. Are there any downsides to some of these medications?
There's really no downside to the propofol. It can be used for IV sedation. We use it very routinely in the endoscopy suite for sedating patients for colonoscopies or EGDs. It's sometimes used like in an ICU type setting for a very heavy sedation. And then, of course, we're using it as a general anesthetic, and it can definitely be used in that way too. So really no downside from that standpoint. It can decrease blood pressure if it's given in a large amount. But again, that's why that infusion is very important. I can turn it up a little bit, I can turn it down a little bit, and it is going to provide amnesia and general anesthesia during the surgery itself.
And you're right there with the patient the whole time. So
yes, I am there monitoring the patient the whole time while a patient is asleep, either from the IV infusion or from anesthesia gases. An anesthesiologist is busy monitoring the patient's heart rate, blood pressure. If a patient is getting a little bit on the light side, that usually means their blood pressure gets a little on the higher side. Their heart rate may get a little faster due to some sort of stimulation. And that usually tells me, hey, they need a little more of the anesthesia. If it's the opposite and their blood pressure is a little on the low side or their heart rate is a little on the slow side, then that lets me know, hey, they're a little bit deep. Maybe they don't need to be quite that deep under the anesthetic. And so, yes, I would be there monitoring them throughout. The Zofran and Decadron, those drugs just are very good at preventing the nausea and not really any downside. The Decadron can cause some patients, and it tends to be more in the older population, they get a little steroid excitement. So sometimes they'll say, I didn't want to lay still in the bed. I wanted to wiggle and I wanted to move, and I felt like I needed to get up and vacuum my room and clean the bathroom. And it's like, but you just had surgery. You don't need to do any of that. And sometimes the steroid will do that. It is just a one-time dose, so we don't normally see much of that. Patients that are diabetic, the steroid can also increase blood sugars. So that's something we want to watch in someone who's not well treated with their blood sugars, we may want to avoid it from that standpoint. Toradol is another very good drug, like we talked about, that we like to use to help decrease the narcotic use, but it can cause some kidney issues. So someone that has some early renal insufficiency, definitely for sure renal failure, we would want to avoid it in that population. And that really is our best way to approach post-op nausea and vomiting. But we have to be aware of it. And that's one of those things. Every once in a while, we'll have someone sick in the recovery room, and the patient will say, "Oh, I forgot to tell you that I always get sick." It's like, tell us. Please tell us ahead of time, and we will do our best to try and prevent that from ever happening.
Good. Yeah, it's enough to anticipate the surgery and the recovery. So it's nice to know that if that's another thing that a patient is worried about, that you have a lot of good answers for that.
Yes. And we like to check on you once surgery's done and you're in the recovery room. I make a point to go by and check on you the first 30 minutes, the first hour. How are you doing? And if you as a patient have had no problems with post-op nausea and vomiting with my anesthetic, then I want to write it down for you so that when you have another surgery in 5 years or 10 years, you can say, this worked really well for me. And you can request that at your next surgery appointment. Hopefully you don't ever have to have surgery again. But if you do, it allows you some leeway to hopefully not have trouble that time.
Right. And I know patients will often ask that, what did they use last time? Because that worked really well for me.
Yes. And, nowadays with the electronic medical records, we are able to easily look back, especially if it's been at a facility that we're associated with. We can look back in those charts and see what was used and try and tailor an anesthetic like it was the previous time when the patient had no troubles.
Yeah. Well, thank you so much. This has been really good information, and it's been really good to talk to you.
Well, thank you too. I have enjoyed getting to visit with you and share this information. Bye.
Talk to you another time.
Alrighty.
Bye.
Thank you for watching SheTV.com, where board-certified physicians talk to you about women's health. If you would like to schedule an appointment with one of the physicians at Lakeside Doctors Gynecology and Obstetrics, here is the office contact information.